did it again. Here we go. We're not in presenter view, right?
That's correct. It's
Okay.
full screen.
All right. Okay, well, here we go. So I thought it would be cool to talk about a new disease process in pediatrics that we're seeing in the setting of COVID. It's very rare, but I thought it's worth talking about, especially for everyone who are first line providers. First off, I know today's a pretty tough day for some people, so I guess I just wanted to say thank you to all the first responders out there, and just take a little moment of silence to think and reflect. Okay, so we are going to talk about the case definition of MISC and a little bit of Kawasaki disease review, a clinical presentation, evaluation, treatment, and some transport considerations. And this all happened rather fast. If you guys think back to COVID-19 really hitting the East Coast pretty hard, and especially Italy and Europe, they started to see cases in pediatrics of Katie-like presentations with hyperinflammation in children, and oftentimes pretty significant shock and myocarditis. The United Kingdom started reporting this, and they called it PIMS. And then in New York, at the beginning of May, they started to see these similar cases. And it usually occurred about 4 weeks after the start of COVID infections. So in the middle of May, the CDC released an advisory and created a case definition, and the World Health Organization also created a case definition. We're pretty lucky in San Diego, where we have some leading experts on Kawasaki's disease. So you probably saw Dr. Burns and Dr. Tremolay all over the news during the months of May and June. So now we're going to delve into a little bit about the case definition. So this, according to the CDC, any person under 21 with fever, laboratory evidence of inflammation, and evidence of clinically severe illness greater than 2 organ systems to involve neurologic and dermatologic symptoms. I'm just going to move the Q&A over here. Okay. In addition, no alternate plausible diagnosis. And this is really important in all of this, to really consider that this isn't sepsis or new onset leukemia or a rheumatologic disorder. And that's the tough part about this MISC. There needs to be a link with COVID, whether it's an exposure, an RT-PCR positive test, or a serology or antigen test. And if they're not testing positive, if they have a significant exposure, you can still consider this as a diagnosis. The fever is pretty significant. These kids, it's not a subtle fever, and it usually lasts for several days. And then the inflammatory markers that you might get as you're picking these kids up for transport are very high CRP, high ESRs, procalcitonin, D-dimer, probably not getting a ferritin at the average emergency department, but if ferritin was drawn, it tends to be high LDH. Interleukin-6 is more of a research study. When you look at their labs, they tend to have elevated neutrophils, but yet reduced lymphocytes, low albumin, low sodium. So we're going to go through sort of some of the cues that tell you, I should be thinking about this disease process, but also thinking broadly about things I need to treat as I'm transporting this child. So just a timeout for talent. We're going to talk a bit about Kawasaki disease and a quick review. This is a nice statement from the AHA, and so I'm going to hit the high points. When you think about the classic diagnosis of KD, you need to have the presence of fever for at least 5 days. Sometimes they cut that back to 3 to 4 days, depending on what other features you have. And typically you want 4 out of 5 of these features. So cutaneous findings of the lips and mouth area, your conjunctiva are injected without a lot of discharge or exudate. They have a pretty characteristic rash that can appear in different forms. And they have erythema, edema of their hands and feet. And sometimes in the later phases, you start to see their skin start to peel. And they may or may not have some cervical lymphadenopathy that tends to be unilateral. In addition to that, they tend to have these characteristic lab findings. So a high neutrophil count, they tend to have high platelets. Again, much like MISC, they will have high inflammatory markers such as CRP sed rate, low albumin, low sodium, elevated LFTs, and you see white blood cells in the urine, but the urine, it's not a UTI. So these are some of the classic findings you might see with KD. So palmar and plantar erythema, this is where you might see the peeling of skin later on in the illness. This is a really nice example of conjunctival injection without a lot of exudates. And you see this perilimbic sparing, not the best picture. Strawberry tongue, cracked lips. In addition to, if you looked at the oropharynx, it would be pretty red. This is a maculopapular rash, and here we see a unilateral, pretty big lymph node. Here's another nice set of pictures that show some of the classic symptoms of Kawasaki disease. These are MRI pictures. So we can see a coronary artery aneurysm. Here we see the left ventricle going into the aorta, the right coronary aneurysm with this giant aneurysm and actually a thrombus in it. And here again, we see the left MCA with an aneurysm. These are examples, again, this is on MRI of peripheral arterial aneurysms. So axillary subclavian aneurysms, iliac, and femoral artery. So one of the things with Kawasaki disease is you can see pretty significant multi-system involvement. So cardiovascular involvement, respiratory, musculoskeletal, GI, and then nervous system. One of the things that we can see, and this has been a syndrome well described by one of our amazing ED doctors, Dr. Kanagai, and Dr. Burns and Dr. Tremblay, is the appearance of Kawasaki shock syndrome. And a lot of these kids will come to the ICU. They are often a little bit sicker than the average KD patient. Sometimes we can think that this is septic shock or toxic shock syndrome, and it's not. I mean, in that setting, we would be treating these kids with antibiotics in addition to asking the question, do they fit a KD criteria? They tend to have more severe GI symptoms. Their inflammatory markers tend to be higher, and they have multi-system involvement with elevated lactate and coagulopathy. And they have higher risk of coronary artery aneurysms. They tend to be resistant, so they may not respond to the first round of IVIG. So Dr. Burns and our KD specialists really think about, are these kids candidates for infliximab and other immunomodulator drugs? And then they tend to have significant cardiogenic impact as far as LV dysfunction and even some degree of vasoplegia where they have decreased systemic vascular resistance. So in terms of treatment options for Kawasaki disease patients, they, upfront, IVIG is always our first line, 2 grams per kilo. And then plus or minus, depending on the facility you're at, and it really depends if cardiology, rheumatology, and we're pretty lucky we have a dedicated ID team. And it's one of 2 places in the country where we're in an area of specialization here in San Diego and Boston Children's. So I know that Dr. Tremblay and Dr. Burns tend to utilize IVIG and infliximab. In severe cases, they do think about anakinra and some other medications. So I think just knowing what KD presents like gives you a sense of of what you're looking for with MISC, because at times they do tend to have a Katie-like presentation as far as multi-system involvement and some of these inflammatory markers, but there are some subtle differences. So I want to take you back to, this was a recent case, a transport, I think from Rancho Springs, where our team picked up a 10-year-old with fever, abdominal pain, vomiting, headache, neck pain for 3 days with new rash, tachypnea, and increased work of breathing. He is a 100-kilo kiddo, so he was quite obese. He had a history of asthma, but otherwise a pretty healthy kid. No sick contacts or COVID exposure, but he did have a brother who was a teenager, and that may have been an exposure risk for him. So he came in with pretty high temperature, tachycardic. His blood pressure is 90/60, so borderline lower blood pressures, but for a 10-year-old, 90 systolic is acceptable right there. Tachypnic, that always throws you off, is why is a 10-year-old breathing 40 times a minute? Saturating 100% on room air, and he's 100 kilos. His exam findings, he was thankfully awake and alert, but really, his headache was hurting, his neck was in pain, to the point where the team at Rancho Springs wanted to do an LP, and they did do a head CT, but they didn't feel like he was stable enough to do an LP. He had dried, cracked lips, conjunctival injection, no exudate, and he had a painful range of motion of the neck. His lungs were clear, a little diminished in the bases, and he did have some tachypnea and work of breathing. He was tachycardic, no murmur. His abdomen was soft, non-tender, and he didn't have any GI symptoms. It was difficult to palpate his liver or spleen due to body habitus. He was cool in the hands. His feet were warm, but his cap refill was mildly delayed at 3 seconds. He was awake, alert, following commands. He did have some petechia on his ankles and a maculopapular rash on his knees and thighs. So I'm going to take you back to when this all first started. This is an initial paper, I think, published in June by an Overcoming COVID group. And this is sort of looking at COVID throughout the country. And you can see this is cases of MISC and looking at the different states in the US. And you can see that the East Coast saw the majority of cases at this time of year. In California, we only had reported in this study about 7 to 14 cases. In terms of MISC here at Rady Children's Hospital, we've only truly had 3 to 4 cases that have been admitted to the ICU, but a significant number of kids that have been admitted to the floor with milder symptoms. What's unique about the presentation of MISC in relation to COVID, so I take you back to March, and this is the percent of people testing positive for COVID throughout the country, peaking and then coming down, looking at the whole country, and then number of MISC cases. So we see that there's a bit of a lag between COVID peak and exposure. And again, this gives you a good indication of the rarity of cases. So this is 13 cases, so around the country at this time of year that were reported. So clinical presentation, it's multi-system. You have to have had some sort of COVID exposure, or some of our tests are positive. Typically very high fevers. Shock can be common, although we've seen a lot of kids without shock. And very high inflammatory markers. Those are some of the unique findings of MISC. This is a clustering of symptoms reported out in New York, published in the New England Journal of Medicine, and looking at symptom category by age. And you can see, again, multi-system involvement, dermatologic, GI symptoms, these Katie-like symptoms, cardiovascular presentation, and neurologic presentation. This is a report from a webinar early on of cases in New York. And again, I just want to highlight how multi-system this disease is. and how it can mimic a lot of other diseases. For example, a lot of kids came in with really bad abdominal pain, and there were a series of kids that went to the OR for exploratory laparotomies, and there was no pathology on the X-lap. Again, multisystem, neurologic. Now, this is the one thing that stands out. In these kids, if you look at respiratory and hypoxia, unlike acute COVID infections, which have been pretty benign in most children, the MISC doesn't seem to hit the respiratory system significantly. That being said, when you have significant cardiac dysfunction, we do start to see tachypnea and increased work of breathing and hypoxia, but it's not due to ARDS. It's usually due to left-sided heart dysfunction. So the most common symptoms we have been seeing: fever, GI, rash, the cutaneous findings, and neurologic. And I'm going to save a little section for shock and cardiogenic problems. So these kids aren't necessarily contagious because this is a post-infectious phenomenon, and they are usually PCR positive. So they're not necessarily, their viral load and their ability to transmit aerosolized particles of COVID is we don't actually, when we have a child with MISC in our PICU, once we're PCR negative, we can take them out of our negative pressure rooms. And then we're still using universal precautions, but no N95 and not in a negative pressure room. Less common symptoms have been myalgia, respiratory symptoms, and lymphadenopathy. So I want to focus a little bit on the cardiac dysfunction. Not only has it been cardiogenic in that when you get an echo on these kids, they have reduced LV function and plus or minus coronary artery aneurysms, but they also have some degree of vasoplegia. So these kids are they could be warm and vasodilated. If you had the means, they would have reduced systemic vascular resistance. So it's a mixed picture. When we get labs on them, they tend to have elevated troponin and BNP. That you can see ST changes, but nothing specific, not like an MI. And late onset heart block has been reported in these kids. And this sort of brings attention to the importance of a multidisciplinary team taking care of these kids and cardiology follow-up as these kids recover. So when I think about shock and MISC, and this is a really nice slide that I stole from a PICU doctor at Children's Hospital Philadelphia. There's the cardiogenic component where you have impaired myocardial contractility, reduced LV function. This may or may not be, there's a lot of sort of controversy as to whether or not this is an actual myocarditis. And I'm gonna let the cardiologists fight about that. There tends to be some degree of distributive shock. So these kids can be very leaky with lots of vascular inflammation. As you give them fluids, they're going to third space, and oftentimes things can be worse with excessive fluid administration. In terms of hypovolemic, now obviously these kids present as if they're septic. So some degree of what is the right amount of preload for these kids, the right amount of volume resuscitation. That's a really hard line to walk when you first see these kids. Common lab findings, I think these are some of the interesting keys to saying, hey, this could be MISC. They tend to have really high inflammatory markers. So their CRPs are typically in the mid to high 30s. Their ferritins can be in the mid 500s to 1000s, and they tend to have elevated D-dimer. When you look at their CBC, their white count can be elevated, but when you look at the breakdown of the white count, they tend to have a predominance of neutrophils and bands, but not as many lymphocytes. They tend to be thrombocytopenic, so their platelet count is low. And in contrast to Kawasaki disease, their platelet count tends to be high. They may or may not have a mild anemia. If they have cardiac involvement, and this is one of the things we look for, is elevated troponin and BNP. They tend to have mild ALT and AST, and they may or may not have some degree of acute kidney injury. Low albumin, low sodium, which can also be seen in Kawasaki disease. And they are more likely to be PCR negative and IgG positive, so showing us that they've had some exposure to the disease, and this is a post-infectious phenomenon. I thought this was a nice little diagram out of one of the children's hospitals that they're sending out to parents, but sort of the 4 big things to know is that it is rare, it shows up following an infection, it's multi-system, multi-organ involvement, and there's lots of symptoms, which is why you need to keep your differential broad initially. So again, sort of reinforcing that it does help us to know how KD presents, but in differentiating the two, KD tends to have an older age. MIC tends to occur in kids that are older. MIC tends to have lower platelet counts. They tend to have a lymphopenia, so low lymphocyte count, but with a bandemia, and higher CRPs. Troponin and BNP can be higher with cardiac involvement, and lower albumin. So in terms of your evaluation, again, multidisciplinary approach. I think frontline education has been really important. Like our ED has done an amazing job developing a pathway, because you don't want to have to spend like a $1 million workup on every kid that presents with this. So you need to be selective in the cases that you want to review. So in this case in particular, they did some imaging. So you can see he's a big boy. His heart, kind of with this projection, he wasn't considered to have cardiomegaly. I think no formal infiltrates, maybe a little bit of a pleural effusion. His white count was 11. He did have a low lymphocyte count and a predominance of neutrophils and bands. His platelet count was low. He had classic low sodium. His kidneys were okay. Elevated AST, ALT. Albumin was okay, and he did have a mild base deficit and a lactate of 3.5. His ferritin was elevated at 1,000, high CRP. His troponin when he first came in was lower, and it did go up over time. And his BNP was in the 1,000, so high. He was PCR negative and IgG positive in terms of his COVID testing, and a broad infectious workup was done. He was on broad spectrum antibiotics. When we looked at his echocardiogram, he had LV dysfunction with an ejection fraction of 31%. And at that time, we had him on low dose epinephrine. Once we knew this, I think we added a little bit of milrinone and a little bit more epinephrine. And over time, this improved pretty rapidly with his IgG treatment. Because of the severity of his illness, not only did we do IgG up front, but we did start solumedrol. And these are the kids where, with involvement from our rheumatology team and our KD team, we start to think about more aggressive care like anakinra or infliximab. And he ultimately was started on anakinra. Fortunately, his coronary arteries were normal. He did have some mild tricuspid regurg and mitral regurg. In terms of the workup, in terms of the average workup, so I think the case example gives you a pretty clear indication of what we need to look into. These are a lot of things we typically do obtain, but a CBC with differential, a coagulation panel gives you an idea of coagulopathy and whether or not ordering a separate D-dimer can be helpful. A complete metabolic panel looking at their LFTs, their renal function, electrolytes. Your inflammatory marker panel, troponin, BNP, especially if a child has shock, and then VBG, ABG, lactate is always helpful, at least in critical care. I think the one thing that I'm always lucky for is I have the ability to do this in the ICU, but it may not be, you may not be able to do all these things prior to transport. A chest radiograph can be helpful in terms of looking for sources of infection. An echocardiogram when they get to the hospital, and we use a specific protocol so that they look closely at the coronaries and assess for function, and we have involvement with our cardiology team. So in terms of treatment, this is an algorithm from the American College of Rheumatology, and I thought it was a nice algorithm. So we're gonna hone in on this. So does the child have the following? So thinking about the case definition of MISC, very, very important. Have you ruled out other causes such as rheumatologic disorder, leukemia, oncology disorders, sepsis? You have to keep that in mind, because you don't want to miss leukemia in the midst of treating MISC. As we move on, do they have shock? When they have shock, I think this really creates the urge to do a full diagnostic evaluation. If they don't, then think about doing a tiered diagnostic evaluation. But at the very minimum, you're sending off COVID infectious disease markers, plus your CBC, your metabolic panel, and some of your inflammatory markers. As these results start to come back, if you have significantly elevated CRP or other markers, you may want to get additional evaluation that would include ferritin, coag panel, BNP, troponin, EKG, and echocardiogram. In terms of treatment, it's really important to have a multidisciplinary approach. So we have our ID team, our KD team, rheumatology and cardiology, hematology. What we've seen with these kids, some of them are placed on aspirin at some point, depending on their coagulopathy and depending on whether or not their D-dimer is significantly high, because they can have a high risk for thromboembolism, VTE. All about supportive cardiopulmonary care. This is the tough part, is what we've seen in some of our patients admitted to the ICU is up front, they received a significant amount of fluids, which is understandable. I mean, when we think about sepsis guidelines, that's the key. In pediatrics, it's 20 per kilo times by 3 over 15 minutes, reassessing in between if you're causing fluid overload. These kids are really susceptible to fluid overload and vasoplegia. So in these kids, if you're really suspecting MISC, and this is hard to do up front, really think about early use of vasoactives. You still have to think about your infectious workup and treatment. So these kids are put on broad spectrum antibiotics, and you've got a full workup pending. So as with our 10-year-old that was admitted within the last month, we started off with IVIG, 2 grams per kilo. We started to see good response from that because of his severity of illness, his shock, the fact that he was on vasoactives. He was started on Solumedrol. When kids are really sick, some centers are doing pulse steroids. We haven't had a child that has been that sick to this point. And then the use of these special drugs that rheumatologists and KD doctors use. Anakinra is an IL-1 receptor antagonist. When you have this inflammatory response and you were to send off inflammatory markers that are more research-based, they tend to have high IL-1. So this can be a really safe and helpful drug in these kids. Infliximab is used quite a bit in kids with KD, and this is a TNF alpha blocker, so it will reduce the amount of TNF alpha, another inflammatory cascade product. Let's see, transport considerations. So I always think about my transport team, and and how are they going to think about and transport these kids. I think you still, again, you're keeping your differential broad. You're not going to be able to say, you know what, this is for sure MISC, because you don't want to miss the kids who are septic. But be sure to treat the septic shock until you're sure that this is MISC. I think the tough part about these kids is when they are in shock, and that's a rare case. They tend to be, it can be due to vasoplegic, low SVR, and cardiogenic shock. So really thinking about using, in pediatrics, we would tend to still reach for epinephrine in these kids. In adults, they might even consider reaching for norepinephrine given the vasoplegia. Consider early use of vasoactives. Use fluids wisely. I think anytime we do give fluids, we're always asking the question is, did it help? Did it hurt? Do I have rales or crackles on exam now? Is my liver down? But sometimes you need to give fluid just to get through the transport, and we will be okay. When they get here, we can use BiPAP if we have to intubate, and we can diurese them eventually. So whatever you need to do to get them safely to the PICU it's what you have to do. This went faster than I thought, I'm sorry. But questions. I love this. Why don't ants get sick? Because they have little antibodies. And then, thank you. I guess I could stop my screen share. I don't know.
Thank you very much, Dr. Harvey.
Yeah.
So we can open it up to questions. You can post those questions in the webinar chat, and I'll relay those to Dr. Harvey for you. So Dr. Harvey, I don't know if you can see the chat. There's actually nobody's posted any questions yet. Did such a great job covering all the topics.
It's tough. Usually I try to be a little more interactive with these talks, but it's the nature of Zoom.
Oh, okay. Actually, they're posted here
go.
in question and answer. So on behalf of Honda McFadden, she asks, what do you recommend for satellite non-pediatric EDs do for frontline treatment for the MISC kids before transport?
I think it's tough because you can't be sure that it is MIC, and I don't think the ability to give IVIG. I would wait until they're seen by our KD team and our room team. So I wouldn't necessarily throw IVIG at them. So I think the most important thing is the workup and recognition, and knowing that too much fluids can be detrimental, but this is sepsis. So I would make sure that you're treating for septic shock as well until we know for sure that this is MISC. I see another question. How common is it? It's pretty rare. We're learning more and more as time goes on. I think one of the illustrations that I showed, like in terms of number of cases in New York, where they have seen the highest number of COVID, it's the cases were less than 100 in that highly populated area. To give you an example, in San Diego, we've seen 4 kids in the ICU, but there have been more kids admitted to the floor. And I think, and I could be wrong, there's been a total of about 10 to 15 kids total admitted to the hospital. In terms of recovery and lasting effects, that's a really excellent question. We're not sure. And that's why it's really important that these kids have follow-up with cardiology in at least a minimum of 2 weeks post hospitalization, and they will get a repeat echocardiogram, looking at their function for recovery and also looking for risk of coronary artery aneurysm. So it's something we don't know yet.
And I think there was one more question from Oscar Vasquez. He asked, have you seen an increase in ped COVID cases that show Kawasaki-like symptoms?
Not the acute infection. We've seen a pretty distinct separation between the two, but other sites who are seeing more have seen it's very hard to separate out kids who have acute COVID infection that might present in shock with ARDS with high inflammatory markers. And those kids are usually RT-PCR positive. They're not IgG positive. And then kids who come in 4 to 6 weeks later with shock, IgG positive, and sort of this MISC picture, they can blur. And that's the tough thing about all of this, is there is a spectrum of presentation, and you just have to get a good history and do everything you can to make sure you're not missing other diagnoses.
Awesome. We'll give it a little bit more time for Q&A. Also, it looks like your chat team said awesome job from Jess, Tara, Heather, and John.
Woohoo! I love our chat team.
Laura Jens asked, what do we monitor for in-flight with these kids?
I would monitor them much like you would monitor any kid with septic shock. It's not, I guess it's pretty tough to hear their breath sounds while you're in flight, I can imagine, but I would not hesitate to start vasoactives if things aren't getting better with fluids. Great question. Oh, sorry. Do most kids have pre-existing conditions? No. A lot of these kids are healthy. If anything, especially with our like separating MISC from acute COVID, we have seen a slight increase in incidence in our kids that are obese and do have asthma. But in the MISC patients, they're usually healthy kids.
All right, I'm not seeing any more questions. Oh, there's one right there. Can you see the one from Michael Gandy?
Yeah. Are there any long-term complications for these kids after the infection? So after a COVID, like the actual acute COVID infection, I think it is important to know that in rare cases, they could have MISC 4 to 6 weeks down the line. So I think that's one thing to be aware of. I'm not sure like long-term recovery from acute COVID in pediatrics. I think overall kids are doing quite well, but if they were really sick in the ICU with ARDS, I imagine they still have some lung recovery to do. In these kids with MISC, so the post-infectious repercussions of being exposed to COVID, they're the ones who again need really close cardiology follow-up, and they may still be at risk for forming coronary artery aneurysms. We know their heart function does get better over time with treatment, but a full recovery, I imagine, happens. But again, I think it's all about good follow-up with cardiology and their pediatricians.
So we got a question in chat. At Loma Linda Children's, we have seen a dramatic increase in DKA positive COVID. Have you seen DKA positive COVID develop MISC?
We haven't, but one of my colleagues graduated from CHLA, and he stays in contact with a lot of his colleagues up in LA, and they've seen some categories of kids that are DKA and fit this MISC diagnosis, and that I can't imagine how challenging is that. You have a kid who's new onset DKA with MIC, who's acidotic due to the DKA, as well as potentially in shock due to issues with MIC. But we haven't seen that here in San Diego. We have, however, seen a lot of DKA, and I don't know if that's just because kids are at home more and they're less compliant and they're eating more cake. I don't know. Let's see, there's a couple questions. What are the important things to teach the parents when discharging home with possible COVID from the ED? We test and send them home and receive results, stay home, etc. No admission criteria, but I feel they need additional teaching on discharge. Yeah, that I think that's really a tough situation. I think there are some really great parent handouts out there, and I think the CDC does a nice job describing what parents should look out for. I honestly, Dr. Kanagai and Dr. Mike Gardner here at Rady Children's, they're doing a lot of work with how to decide which kids are being screened, who goes home. So they might be better answering that question as far as helping parents with the right anticipatory guidance. I can, if you email me, I can forward you their information. Lucky for me, I just deal with the things in the ICU. Let's see, Ashley Gonzalez says, I work in a rural hospital where most of the complex pediatric cases get transferred to Rady via ground or CHET. What do you recommend for management while a patient is waiting transport? I think, again, it's all about your continued cardiopulmonary supportive care. So you're going to do an infectious workup. You're going to start them on antibiotics. The ability to send off some of the inflammatory markers can be helpful, like CRP, and then just that basic workup to start. But I don't think you're going to be giving IVIG or steroids at these outside facilities without talking to some of the specialists. And I think it's okay up front for that mild delay while you're sorting out, is this a more common condition like septic shock? So I would continue to treat your kids, have an index of suspicion for MISC, but you've got to treat the shock like you would and in terms of sepsis. If you notice as you're giving a lot of volume, things are getting worse with fluid overload, crackles, rales, your liver's down, then stop giving fluids and really start those vasoactives. But it's a tough situation to be in. Thanks for all the great.
Go ahead. Sorry.
I was just going to say thanks for all the great questions. This was a lot of fun.
So we don't have any open questions at this time. If there's anything further, otherwise we can start looking at closing things out just a little bit early. Oh, do we have a website with this information also?
The CDC has good information. There's also we're involved in a research with Boston Children's Hospital and the CDC, and it's a huge multi-center collaborative called Overcoming COVID. And the website, if you Google overcoming COVID, I think it'll come up, and there's some really good data about MISC and acute COVID infection in pediatric patients. I think those would be two really good starting points. There's been a number of wonderful New England Journal of Medicine and JAMA reviews as well on MISC. And I can send my slides to Thomas and Russ. Oh boy. What challenges do you see with COVID and the winter season in peds? I think that's one thing we're all really worried about, is what's going to happen if and when we have an influenza peak with bronchiolitis and all the viruses that come along with bronchiolitis, in addition to infection with COVID. We're worried about it. So I think that what some of the webinars are saying as far as multi-site PICUs is co-infection with other viruses. We are worried that the severity of illness may be higher. I think we've been really lucky in pediatrics though, in COVID, from the standpoint, we're not seeing the acuity and severity that adult patients have. And when we are, it's usually in our patients that have a lot of comorbidities. So we've been quite sheltered compared to the adult experience. I can send my slides to anyone. Yeah, absolutely. I think we're really lucky, again, to live in San Diego, where we've got such expertise with Dr. Burns. And honestly, she will get on the phone with anyone, any time of day. If you are calling her from any ED around this area, she is so happy to help guide and talk to people about MISC. So don't hesitate to utilize that resource as well. And you know, those kids will get good care. Suspected COVID, do you guys transport with high flow or BiPAP? That's a great question. I think we've done, this is probably a good question for our chat team. Maybe someone's on the line, but in general, we will use, Jess just said, yes, we do. These kids will come in on both, especially the little kids. Our chat team does a really nice job creating like sort of a CPAP system, even with the anesthesia bag. So crazy, this Zoom environment. We just started our interviews for fellows with Zoom. But it's good. You guys could be sitting in your living room learning about MISC. Let's see, here we go. Oh, Jess just answered, we do high flow or RAM via our T1 and BiPAP with higher pressures. We've got a really cool transport ventilator through Zoll. Did I say it right? We actually have only had a few COVID positive patients with significant pulmonary disease, and only one kid with true ARDS. So again, like our experience at Rady Children's, and we compared to our adult colleagues, kids are staying healthy. Should knock on something. Sorry, guys. I think another interesting aspect of all this is I think understanding this disease process and the post-infectious triggers that cause it will help us there's so much resources, research, multiple people are looking at this. I think it's going to help us understand other diseases that are triggered by infectious causes. So hopefully this helps us understand Kawasaki disease a little bit better.
All right, guys. Well,
Woohoo.
Thank you very much to Dr. Harvey for presenting today, as well as thank you all for attending and modifying plans this year with related to the pandemic and having this online. It's very much appreciated. On behalf of all the sponsors for the SoCal ECC, which includes Express Training, as well as UCSD, Rady Children's, and Mercier, we all thank you for keeping the conference going this year and for many years to come. Your CE credits or CEUs will be emailed to your email that you registered for the Zoom webinar and those will come out in the next about 5 business days. You'll receive those from Express, as well as we'll try to attach Dr. Harvey's PowerPoint with that. And then last but not least, of course, try to register for the other 3 webinars. They're coming up every Friday, 1 p.m. Pacific time, and those will include CE credits as well. You just have to register for those individually. You can message us on Facebook or to the Mercier Instagram, Mercier Facebook if you're having any troubles, and we'll be there to help. Jess, the topics are listed on the SoCal ECC Facebook page. There's also a surprise topic that I'll be posting here shortly on there as well for our 4th surprise speaker. All right, with that, we'll go ahead and end this session of the SoCal ECC. Thank you very much to everybody that attended.
Thank you.